Fine. Good evening, all. Myself, Dr. Arun Paul. I'm Associate Professor in the Department of Public Health Dentistry in Chemistry Dental College. And I'll be talking about a short topic, topical fluorides. And within topical fluoride, I'll be dealing with two important fluorides, that is sodium fluoride and APF. So we'll go on to the session. In between, if you have any doubts, you can always. Yes.
Yes, sir.
The PPT is visible. The audio is all fine.
Yeah, very fine.
Fine. No. Okay. Fine. Good.
Sir.
Yeah. So fluorides, we know the element that it has been widely responsible for anti-caries effects, and we'll move on to what is the mechanism by which this topical fluorides act upon. It has been literature says that the topical fluorides or the fluorides which you apply topically onto the tooth surface, that is superficial tooth surface and the enamel, they predominantly act by 5 mechanisms. So first is by increasing the enamel resistance or by reducing the enamel solubility. The second is by increasing the rate of post-eruptive maturation. So we'll see what exactly it means. That we know that the acids produced by the plaque microorganism, the main reason why acids are produced in the oral cavity is because of the bacteria which is beneath the plaque which is attached onto the tooth surface. So that is an interface where the acids have been produced. So this acid producing bacterial plaque which results in the byproduct of this acid, that is lactic acid, results in enamel dissolution. And for a prolonged period of time, if this acid attack is present, it results in dental caries. So fluoride predominantly act by reducing the solubility of enamel. That is, it acts upon this minerals what is responsible by forming calcium fluoride. We'll see in detail how the calcium fluoride is formed. So that is a predominant mineral which forms when fluoride acts on the tooth surface, and this prevents the dissolution. So that is one important compound formed. And again, when more fluoride is being acted upon on this calcium fluoride, it again results in a compound called as fluorapatite. So this is a major compound which results in the anti-caries effect of fluoride. That is a fluorapatite, a very important compound to be remembered. Next is it increase the rate of post-eruptive maturation. So when a tooth has been erupted inside the oral cavity, there are a lot of hypomineralized areas. That is those areas which have not been completed the maturation, or we call it as a phase of post-eruptive maturation process has to be taken once the tooth has been erupted inside the oral cavity. So this usually takes almost 2 to 3 years once a teeth is being or the tooth has been inside the oral cavity. So when we say that first permanent molar by the age of 6, if it erupts, it takes around 8 to 9 years for complete maturation. So there are a lot many hypomineralized areas which will be seen. So this hypomineralized areas are highly susceptible for dental caries. So fluoride act upon by mineralizing these hypomineralized areas. So it fastens the process of maturation. So the mineralizing these areas are called as the post-eruptive maturation. So that is different from remineralization. Remineralization and post-eruptive maturation is different. So this post-eruptive maturation is usually happening in your hypomineralized areas, whereas remineralization happens in your demineralized areas. Yeah? So next is your remineralization of incipient lesions. So just what I told you, there will be areas once the tooth has been inside the oral cavity, once it has been exposed to the oral environment, acid attack, there starts incipient lesions or small areas of demineralization. So fluoride plays a very vital role in remineralizing these demineralized areas. And we have learned about the pathway called as glycolysis, which is solely responsible for producing the acid by the bacteria. So that is one major pathway which the microorganisms undergo for production of acids. and it has a rate limiting enzyme called as enolase, and the fluoride act by inhibiting this enzyme enolase, thereby preventing the formation, preventing the formation of acids. And that is the reason how fluoride interfere in plaque microorganisms, the action of plaque microorganisms. And finally, it plays a very important role in tooth morphology. It has been said, the literature describes about the role of fluoride during its developmental stage. When the fluoride is being consumed during the developmental stage, the anatomical variations or aberrations in the tooth will be reduced. That is, the pit and fissures or the fissures which you come across in the tooth surfaces won't be very deep and narrow. It makes more self-cleansing fissure systems. So that is how the fluoride plays a major role in altering the tooth morphology. So these are the main mechanism by which the fluoride or topical or systemic whatsoever fluoride act on the tooth surface. So these topical fluorides are those systems or delivery systems which provide a very local chemical reaction to the exposed tooth surface. So as the word says, it is topical, it comes superficial on the contact of the surface or surface of the teeth. So it was a need after systemic fluorides or water fluoridation studies. It was found that these fluorides, the systemic fluorides, are not much effective on the occlusal surfaces of the teeth. So to counteract this effect, or to find a substitute which can act predominantly on these occlusal surfaces, the only solution was topical fluorides, which were given at higher either in a higher concentration or in a lower concentration for a prolonged period of time. So dentifrices are examples of that. Whereas you have certain mouth rinses, certain gels, which we'll be seeing that. So there are variety of topical fluorides which are given in different forms. Some will be given in a very high concentration of 19,000 ppm, but the frequency will be very less. Some topical fluorides will be very less concentration, that is within 1,000, like our dentifrices. It comes around 900 to 1,000 ppm, but it will be in a regular way. Yeah. So, what are the indications of this topical fluorides, or when do you give this topical fluorides? The first, we would say caries active individuals. When do you call an individual to be caries active? Usually we say that caries activity or the caries nature will be progressive or active in individual if he has active lesions inside the oral cavity. It includes cavitated or deep lesions. The best way to identify a caries activity of individual is either by caries activity test, or most simple method is your index, that is your DMFT, DMFS, or any caries index. This gives a very good picture of whether the individual is active caries. His cumulative caries rate. It could be both active and his past caries experience. So an activity or caries activity of an individual is set by both present and past. So it is a cumulative. And it is very important or highly indicated in children with shortly after periods of tooth eruption. So this is a reason why I talked about post-eruptive maturation. A tooth, when it is newly erupted inside the oral cavity, it is highly susceptible because of hypermineralized areas and because of because of a phase called as post-eruptive maturation. So that is a very critical period, and if a tooth can be saved from that period by application of topical fluorides or by all hygiene or diet instruction, the tooth can stay caries free for a long period. Again, these are indicated in those individuals who take medications that decrease salivary flow. So saliva is a very important constituent for supplying the constant supply of these minerals, predominantly calcium and phosphate ions for the tooth. And these are very important for forming remineralization or to make the crystals, enamel crystals, more strong. After periodontal surgeries, so usually after periodontal surgeries, the root will be exposed, so cemental caries. So in those individuals, even it is indicated. Fixed and removable processes. Again, when patients have more processes, there are chances that the tooth surface will be exposed, the cementum and the root surfaces, and there'll be more areas of contact with of the appliances onto the tooth surfaces. And patients with eating disorders. erosions are very common, or the wearing of tooths are very common in this individuals. So these individuals, fluoride are highly indicated. And we have different types of topical fluorides. So predominantly it are classified into professionally applied and self-applied. So as the word says, professionally are those topical fluoride system which are delivered by the dentist, dental hygienist, or the auxiliaries. Self-applied are mainly by the patient himself or the person. So the main reason for this classification is based on the concentration. You know that professionally applied are done by patient, dentists or professionals, so you can bound to give a higher concentration because it is under supervision. Whereas self-applied are patients, so there are high chances of toxic effects. So it is given for a very low concentration of 200 to 1000 people. So these are examples of dentifrices of mouth, toothpaste, mouth rinse, gel, fluoride chewing gums, toothpicks, dental tape, and floss. Whereas professionally applied are sodium fluoride, stannous fluoride, APF, varnish, restorative materials, and fluoride releasing devices which are attached onto the tooth surfaces. So today we'll be talking about sodium fluoride and acidulated phosphate fluoride. So sodium fluoride was one of the first fluoride compound to be used for topical application. And this, the reason why topical fluoride, many studies were done on topical fluoride because it was very economical and it is very easy to use. And it had very less side effects when compared to others. So this topical fluoride or fluoride delivery systems, or most of the studies were done primarily on sodium fluoride. It was first, in fact, described by a person called as Bibi in the year of 1941. So he had done the first clinical study using 0.1 percentage of sodium fluoride solution. Then later, the method of sodium fluoride application was described by a person called as Knudsen. So this is a very important date, which is mostly given in your textbooks, that is 1942. Although the first ever reported mentioning of sodium fluoride was done by Bibi in the year of 1941. So he was a pioneer researcher with respect to many of the fluoride solutions. So Knudsen's technique is known as the application of fluoride solution is called as this Knudsen's technique. It uses 2%, that is 2 gram in 1 liter of solution, and the pH is 7. So since the pH is 7, it is also called as neutral sodium fluoride. And the sodium fluoride is applied 4 times. There are 4 applications are done, and it gives a caries reduction of approximately 30 to 40%. Just 2% of sodium fluoride is prepared by dissolving 20 grams in 1 liter of distilled solution, and it is always stored in a plastic bottle. Very important. Most of the fluoride solutions are stored in a plastic bottle because of the reaction of fluoride with the glass, that is silica particle. If you store in a glass particle, the silica react with the fluoride and form silicon fluoride. So the availability of fluoride will be compromised when you store it in a glass bottle. That is the reason why it is always stored in a plastic bottle. So very important point. The application is called as Knudsen's technique. So before you apply any topical fluoride solution, the first thing you do is an oral prophylaxis. A thorough oral prophylaxis will be done. Patient will be made to sit on the chair in upright position. Thorough oral prophylaxis and polishing will be done. You can either do a quadrant-wise application of sodium fluoride, or you can do in a section. So you isolate one particular quadrant or a particular arch using cotton rolls and suction, and you start applying it. And the treatments, as I told you, the treatments are given an application of 4 intervals. That is, at 4 intervals at 4 different age groups. Clear? That is at the age of 3, 7, 11, 13. So these are kept as the age groups where you are supposed to give sodium fluoride. So this is in relation to the eruption pattern of the teeth. So as the primary teeth erupt around 3, 6, the first permanent molar, 11, and 13, by the age, almost all permanent teeth most probably will be erupted. So coinciding with the eruption pattern of primary and permanent teeth, this age has been decided. And at each age, the patient has to make 4 visits in a interval of 1 week interval, 4 visits at each age. So that is again a biggest demerit of uh, sodium fluoride, that the number of visits a patient have to make is very high. And the technique of application is paint on technique. Usually we use two techniques, normally two techniques on topical fluorides. One is tray techniques and one is paint on technique. So paint on technique is applied by you take a sufficient amount of sodium fluoride in a dispenser and using unit tufted brush or a dispensing brush, and you apply onto the surfaces of the tooth. Whereas in your tray technique, you have either custom trays or free fabricated trays, which a minimal amount of sodium fluoride is dispensed and it is applied. Now let's see what are the mechanism of action of topical fluoride, I mean sodium fluoride. How does sodium fluoride act on the tooth surface? So when this sodium fluoride in this solution form or gel form, when it applied onto the tooth surface, we know that tooth has hydroxy or made up of hydroxyapatite crystals. The sodium fluoride act upon hydroxyapatite crystals. The first formed compound is calcium fluoride, or the predominant compound formed is calcium fluoride. So when this calcium fluoride is formed, it forms a thick surface on the tooth surface. Yeah. So you have a tooth here. You always have a biofilm here, plaque biofilm, and here you have the environment. And this is the area interface where the remineralization and demineralization happen. That is plaque biofilm and tooth interface. Yeah, this is a very critical area. So calcium fluoride forms a layer over here, a thick layer over here, and this interferes with, when more calcium fluoride start forming, this interferes with the further diffusion of this fluoride from the topical fluoride onto the tooth surfaces. Thereby, it prevents the entry of fluoride. So more fluoride from the external surface. Fluoride are being supplied from external surface. This fluoride ions cannot enter because it forms as a barrier. So this particular phenomena is called as chalking effect. Yeah. So it is very simple. That is chalking. It acts or it suffocates or it prevents or it acts as a barrier of fluoride penetrating through this layer of calcium fluoride into the tooth surface. But the best part is calcium fluoride, in fact, act as a reservoir because it has a lot of fluoride. It start leaching, the fluoride again start leaching slowly into both sides, that is to this external environment and to the tooth surface too. So that is a added advantage of calcium fluoride. So that is the reason why it is act as a reservoir, and that is the reason that fluoride is left to dry for 4 minutes. So that is once you apply on the tooth surface, you don't disturb the solution which has been applied for at least for 4 minutes. So it has to form a very good thick layer. So that is more of theoretical. You can't actually clinically visualize a thick layer, but that is what is being described, that the topical fluoride which has been applied should be undisturbed for 4 minutes. So when this calcium fluoride again act upon this hydroxyapatite, and the final product which forms on the tooth surface, the desired product is called as fluoridated hydroxyapatite, or fluorapatite is formed, and this is the most important component which prevents dental caries, that is, which is resistant to dental caries. So this is how a sodium fluoride acts. Now, some of the advantages of sodium fluoride is it is very stable when kept in a plastic container, and there is no need to prepare a fresh solution for each patient. That is, it has good shelf life. There are some solution which has to be prepared freshly. It is well accepted. The taste is well accepted by patients. It does not cause any irritations or irritants or blanching to the gingiva, and it does not cause any discoloration to the tooth structure too. So these are the added advantage of sodium fluoride. Next, and the only disadvantage when concerned with sodium fluoride is the number of applications becomes a big problem. Apart from that, sodium fluoride is a very well acceptable topical fluoride. Next, we'll talk about acidulated phosphate fluoride, or APF. So again, this was initially the first research was done by BB in 1947. Later, Bredewald and his co-workers in 1963. There are two dates given. Some textbooks say that 1960. So 1960-63 reported that they came to a conclusion or came to an inference that if the pH of a solution or the pH external to the oral cavity, that is your tooth surface, is been reduced, or under acidic environment, the absorption of fluoride is much higher. So that was a inference what they found. So when this tooth in vitro studies, when tooth was subjected under this in vitro study, they found that fluoride absorption were higher into the enamel. So based on this inference, they developed a solution called as APF. Again, it was 20 grams of sodium fluoride in 1 liter of phosphoric acid. So there was a new acid used, that is 0.1 m phosphoric acid. And apart from that, they again used one more acid called as hydrofluoric acid. So this hydrofluoric acid was done to adjust the pH to 3. So this was what we discussed the previous slide. They wanted to bring the environment to be very acidic. That is, 3 is an acidic environment, whereas neutral sodium fluoride, it was 7. And the concentration to be 1.3. And apart from that, they added a gelling agent called as methyl cellulose or hydroxyethyl cellulose. This again to adjust the pH to be around 4 to 5. Okay. So that is 3 important compounds added in APF. One is your phosphoric acid, hydrofluoric acid, and hydroxyethyl cellulose or methyl cellulose. So this is a gelling agent. Again, one problem with the topical fluorides was to keep them moist for 4 minutes. So gel had its own limitation. So more refined, and nowadays what type of topical fluorides we come across has a type of agent called as thixotropic gels. That is those which yields under pressure. It is not unlike your previous gels, because these gels, they don't tend to sometimes cover entirely, especially the proximal surfaces are covered. So this thixotropic gels have a very good property of yielding when you apply pressure, and they sets. So they're a little bit more easy to handle. So thixotropic gels were used, and the gelling agent were methyl or hydroxyethyl cellulose. So again, for application of APF, the steps were same. You make the patient to sit upright. A thorough oral prophylaxis will be done, and isolation along with suction tips and air dried. And here we use, since it is a gelling agent was used and it is in the form of a gel, a disposable foam lined tray was used. So please remember what is a tray. It's a foam lined tray, foam, that is disposable tray. So very minimal amount. So the tray has a trough inside, there is a small mark inside. So you almost take 1/3 or less than 5 ml of solution or gelling solution inside this, just like how you load your alginate, very minimal amount, less than 5 ml or 1/3 of the trough of the tray. You place a saliva ejector, you ask the patient to move his tongue, just like how you maneuver techniques what you use for your impression taking, such that the gel flows entirely to the tooth surfaces, all the surface of the tooth. And finally, you ask the patient to expectorate. Fine, you don't ask the patient to swallow, you ask the patient to expect, that is, spit forcefully the remaining fluoride or the remaining solution what is there inside the oral cavity. And never ask the patient to rinse the oral cavity, because you need the fluoride, the calcium fluoride, the compound formed in the oral cavity act as a reservoir here, and it slowly release fluoride. So this has to be kept in mouth for at least 4 minutes, and remaining oral fluid should be expectorated. And ask the patient not to drink for 30 minutes. And a very interesting compound is formed when APF acts upon the tooth surfaces. So when APF is applied onto the tooth surfaces, as it is due to its very high acidic environment, initially it causes shrinkage and dehydration on the tooth surfaces. And it results in a formation of a compound called as DCPD, that is dicalcium phosphate dihydrate. So that is a compound which form when APF is applied onto the tooth surface. And this is highly reactive, and it results in a formation of fluorapatite. So always this is our end desired product. Fluorapatite is always our desired end product. Unless and until fluorapatite is formed, it does not what do you say? It does not help you to form anti-caries. It does not exhibit any anti-caries effects. So dicalcium phosphate dihydrate is your intermediate or the compound form which is responsible for anti-caries effect in your APF. And some of the advantages of APF is you have semi-annual and annual application, unlike your sodium fluoride, which had 4 applications at 4 age groups. You don't need that. You either annually or semi-annual. It is very chemically stable and it can be stored for ready use. And it does not, although sometimes this APF, since because of very acidic nature, it can lead to be little corrosive in nature to some restorations. But when comparative sodium fluoride, it does not cause any staining onto the enamel surfaces. But it causes some certain corrosive properties to have reported to the your composite restoration tooth colored materials what you place on the tooth surface. And one of major advantages, this can come under various flavoring tastes of flavoring agents, which is very pleasant for the children. And expected caries reduction is 30 to 40%, and it can be used even for home use since it has been in the form of gels, that is self application is also possible. Some of the disadvantages of APF is, so it by the methods of application, we know that that it has to be placed at least for 4 minutes. So you need a suction. So at least for the use of suction on this isolation, sometimes it becomes difficult when you do or conduct certain programs in your camps and field studies, or in chair side. What you do in clinic may not be possible in a field setup. So that again is a limitation when you need high suctions and other isolation techniques. And chairside time is also increased, and it cannot be stored in glass containers. And sometimes prolonged exposure, that is what I told you, prolonged exposure can lead to some corrosive effects of and surface roughening of porcelain. So this is again important point to be noted. Surface roughening or cosmetic changes to the porcelain and composite restoration is caused one of the limitations of APF, whereas sodium fluoride does not have any such side effects, only is with respect to your application, number of applications. Fine, so that completes the two important sodium fluoride and APF, and we will see in detail from next month onwards. When we start our regular sessions, we'll go in detail about each solution. We'll have a comparison between each solutions. Fine. So before I wind up, I will just quickly go through some questions which I want all of you to answer. Very simple questions, and these questions have been asked in your previous exams. Okay, so chalking effect is seen with. Chalking effect is seen with. Very good, very good. Yes, Dr. Harsh. Oh, okay, I can see some familiar names again. And good to see you all back. Good. It's a very direct question, very favorite question. Keep asking. See, most of the papers, recent papers, they ask very easy questions from PhD topic. So if you have a very good reading, you can crack at least 15 to 20 questions, short questions you can crack. Very easy questions, direct questions they ask. Next, Bridewall solution, which is Bridewall solution. Again, the name of solution is again very good. Again, this is a favorite area. They keep asking which is Muller's, which is Knutson's, which is Bridewall's. Very direct questions. Very good. All have given good answers. Good. So very direct and easy questions. APF. So this is answer is APF. Second question. Next. The first compound formed, or the first form compound when sodium fluoride reacts with tooth surface. Excellent. Some Dr. Sunny Joseph Achna. Good. It is your calcium fluoride. So irrespective of whatever type of fluoride, the first form compound is always sodium fluoride, and it is as the type of fluoride, a type of different fluorides, they wanted to reduce the amount of calcium fluoride and more amount of fluorapatite. Yeah, that was the research what started off. After one sodium fluoride, they always wanted to reduce the amount of calcium fluoride, because if more calcium fluoride is formed, it prevents further entry. they wanted more of fluorapatite. Clear? Yeah, so that completes today's short session. Any doubts you have or any points you want me to repeat? I know it's a very simple event session. If you have any doubts, you can always message up here. Okay, I hope there's no doubts. It's all the small session was very clear enough. Is it? Yeah, question number 3. Yeah, question number 3 is like, see, when any fluoride is been applied onto the tooth surface, whether it is sodium fluoride or APF, the first this fluoride from this sodium fluoride or APF come in contact with the hydrox, that is the calcium part. You have calcium, you have phosphate amine predominantly on the tooth surface. So they come in contact with the calcium of this and they form calcium fluoride. Yeah. So as I told, I drew a picture here. You have predominantly phosphate ions. So this fluoride, they are more binding to the calcium. So fluoride from the solution, they come and bind onto the calcium of this tooth surface. So thereby the calcium fluoride is the first compound which forms on the outer surface of tooth surface. Is it clear, Dr. Sujay? Yes. Topics are there. Since I just want to keep it a very small session, that's why I just covered the important two big fluoride topics. We'll discuss the topics in detail when we have a regular sessions. All 4 fluorides are important. Your sodium fluoride, APF, stannous, and amine. All 4 fluorides is important, and equally important are varnishes and mouth rinsers. So you have, it's a very big chapter. So topical fluorides is a very big chapter, but very interesting because you can relate it to your clinical scenarios because you apply it here in your patients. So that is the reason why I picked up this topic. So it's a very huge topic. You have dentrifiers, you have varnishes. So we need a lot of time for that, and we'll discuss all those in detail. Fluorapatite is the final product. It's the most desired and final product which is formed. Again, this the first calcium fluoride form. So when this calcium fluoride again reacts with the hydroxyapatite onto the tooth surfaces. So thereby it forms fluorapatite. So the question was, what is the first compound form, not the final compound. If it was, what is the most important compound, or what is the major compound, what is the desired compound which formed when this fluoride react, it is a fluorapatite. What the fluoride compound which is anti-caries in nature is your fluorapatite, which prevents enamel solubility is fluorapatite. This fluorapatite is formed when fluoride comes first react with the calcium ions. This calcium ions forms calcium fluoride. Then calcium fluoride reacts with the hydroxyapatite of the enamel. And finally, fluorapatite is formed. So that is how the cycle goes. Am I clear, Dr. Sujay? Okay, thank you. Thank you so much. Any more doubts? Fine, fine. Okay, I think I addressed Dr. Sanjay Joseph's doubt and query too. Hope to see you all again. We'll have a very detailed discussion about all the topics. Fine, fine. Anyway, thank you. Have a nice day. Good night. See you all very soon. Fine. Thank you.